Good afternoon, everybody. My name is Tony Lawson, and I'm the chair of the Consumers Health Forum of Australia, national voice for health consumers. I'd like to acknowledge the lands on which we are meeting today. I am on Kaurna land in Adelaide, and I'd like to pay respect to the elders, past, present, and emerging, and also pay respect to all Aboriginal and Torres Strait Islanders who may be present on this webinar today. We are delighted to be hosting the Minister for Health and Aged Care, the Honourable Mark Butler, at our webinar today, which is part of our ongoing, sorry about the dog in the background, part of our ongoing CHF Talks webinar series. I'm happy to say that we have 500 people registered to participate today, which is a big number. CHF has had the pleasure of several discussions already with the Minister about his priorities for health and to share consumer priorities with him. This webinar is now the opportunity for CHF members, stakeholders and consumer representatives to hear directly from the Minister and to engage with him in a real ABC style Q&A style webinar. So welcome, Minister, and over to you to take us through the main issues in health you see or you want to tackle in your first term, and the priorities that you see and how we may be able to assist in advancing some of those. After your presentation, Leanne will then facilitate a Q&A session with you and our online participants. So over to you, Minister. Welcome. Thank you.
Thanks so much, Tony, and thank you to Leanne for organising today's event. I also come to you from the land of the Kaurna people. I'm going to pay my respects to their elders, past, present, and emerging. It's particularly important we do that only a week or two after receiving the latest Closing the Gap report, which reminds us of the continuing and substantial gap in health outcomes and life expectancy between Indigenous and non-Indigenous Australians. And we as a government have certainly recommitted to that work. I'll be working very closely with the Assistant Minister for Indigenous Health, Senator Malarndirri McCarthy, who brings a real passion to this project. I also give that acknowledgement of country as part of a government I'm very proud to say that is committed in full to the implementation of the statement from the heart, most importantly at the outset, by constitutionally enshrining a voice to Parliament. And that will be a very, very important part of this term of Parliament, not just for its own sake, although we think that is important, but because we also understand that a voice to Parliament will make a real difference to the practical outcomes we're able to achieve through government programs. It will improve our ability to do things like close the gap. So I very much look forward to continuing to talk with your members at the CHF about that important piece of work. But I really appreciate the opportunity just to say a few words about my early impressions as the new Federal Minister for Health and Aged Care, and then open up to your gentle and probing questions from, I think we call it the floor, even though we're meeting virtually, but open up to your gentle questions, and we can then have a way forward as the term of Parliament progresses. I had a meeting of health ministers this morning, and we received a report from the Chief Medical Officer, and I've been talking with him yesterday as he and the Prime Minister and I were announcing our response to the monkeypox outbreak as it affects Australia. And I think it's fair to say now that we have some confidence that the third Omicron wave for 2022 has peaked. Certainly not gone away, it's still with us, but it's peaked a little earlier than we had initially thought it would. We thought it would peak in the second half of August. It appears to have peaked now. Case numbers are coming down a little bit, although, given the number of people being infected who aren't testing, That's not a completely reliable indicator, but what is a more reliable indicator, and particularly pleasing, is the number of hospitalisations for people with COVID has come down quite substantially by some hundreds over the last several days, and we're very hopeful that that will continue. It doesn't mean there's not real pressure still on our hospital system. Still almost 5,000 Australians are in hospital today with COVID, which is close to 1 in 12 of our public hospital beds. But the fact it's not gone higher than its peak of about 5,500, I think, is a great relief to state authorities. I certainly got that impression in my meeting with state health ministers this morning. And I think a substantial reason for that is the changes we made a few weeks ago. First of all, to eligibility for fourth doses of the vaccine. And that's been taken up really substantially, particularly by older Australians who have been going out, getting their fourth dose in huge numbers, about 500,000 each week over the last 3 weeks, but also expanding the access to these highly effective antiviral treatments, which has seen a tripling of prescription rates in the 3 weeks since we were able to expand that access as well. So really giving that relief to people who were particularly vulnerable to severe illness and as a result vulnerable to being placed in hospital has had a real impact. This is not, as the Chief Medical Officer reminded people yesterday at our press conference, this is not the last wave we're going to experience though. As I said this morning on Patricia Carvelis's program, we don't really have enough evidence around the world to understand the pattern of this virus. It's certainly not settled into a seasonal routine like influenza has, for example. There is some suggestion that it is going through a much more regular cycle, but we'll probably have some more insight into that after the Northern Hemisphere winter that they're moving into over the next few months. There's very little question in my mind, though, that there will be another wave, and it won't be 12 months away. It'll likely be sooner than that, and we're very much working on a Commonwealth plan that we'll be talking with states about to deal with the sort of more medium to long-term response to COVID. That is going to have to take in a number of, I think, structural things that we should be thinking about around clean air and ventilation, for example. But also, as I said in the Parliament this week, because I was asked about it by one of the new crossbench independents, Sophie Scompes from the Northern Beaches in Sydney. She's a former GP. She's one of the so-called teal independents, and she asked me about long COVID. No, it wasn't her, actually. She asked me about something else. She asked me about climate and health. It was Monique Ryan, another doctor, but from Melbourne, another teal independent, who asked me about long COVID. I've spoken a number of times to the Chief Medical Officer about the need for the Commonwealth to start to put in place a focused response to long COVID. It's a bit variable how many people are suspected of being affected by long COVID across the world. There are different estimates about this, but even a relatively common estimate of 5% of COVID patients having long COVID symptoms, so symptoms beyond 12 weeks after their infection, 5% of the many millions of people who've been affected by COVID or infected by COVID right now already numbers hundreds and hundreds of thousands of people experiencing that. Now, obviously, they can go to their GP and access Medicare entitlements. There are long COVID clinics that states are operating now, although they're becoming overwhelmed and their waiting lists are growing very substantially. But I think we do need to work on a more focused long COVID strategy as we move out of this third Omicron wave and start preparing for the next. That's probably enough for me about COVID. I thought I'd just mention a couple of more structural challenges I think the health system is facing, which are really separate from the pandemic, although obviously have been aggravated by it. If I had to put my finger on the element of the health system that has caused me the most concern since I came back into the health portfolio 18 months ago, it is the state of general practice and primary care. After particularly 6 years of a Medicare rebate freeze over the last decade, over the last 9 years, general practice is really suffering. It's really struggling to remain viable. As we see a lot of the older generation of GPs start to retire, or certainly think about retiring over the next few years, they're not being replaced by a big enough pipeline of new general practitioners. I think the latest figure I've seen is that only 15% of medical graduates are choosing to take on general practice. That's down from a historical position not too long ago, a few decades ago, of about half. About half of all medical graduates wanted to become GPs. And if we continue down at 15%, if you think it's hard to get in to see a doctor right now, in 5-10 years' time, we're going to be in all sorts of trouble, really, in terms of people's ability to get access to care where they need it, when they need it in their community. And we know what happens when there's a failure in the healthcare system out in the community, whether it's primary care, mental health care, aged care, disabilities. People end up at the local emergency department, seeking the care that they can't get out in their community, placing enormous pressure on hospital systems that were really built for, at least the emergency departments, built for once in a lifetime emergencies. So we really need to focus on some long-term work to rebuild general practice. That was really the reason for strengthening Medicare being the centrepiece of our election campaign, a $750 million investment in delivering the 10-year primary care plan that I know Leanne Wells was such an active participant in developing. Leanne's been on more of these bodies than I care to mention, or I'm sure she cares to mention, seeking to chart a better path forward for aspects of our healthcare system, including primary care. The problem was it's a great document, very broadly supported across the healthcare system by clinicians and consumers. The problem was it didn't have any money attached to it by the former government. So we've brought money to the table. I've put together a Medicare task force, which I'm chairing, which I take part actively in myself. Leanne represents CHF. We've already had one meeting, and we'll be having a number of meetings between now and Christmas to make sure that there is some clear advice from that group to the government for next year's budget, so those funds can start to flow next year. We've also announced 50 urgent care clinics across the country. This is really a bit of a trial. I'd like to test this model across the country, see how it works. I'm confident it will work. It will tell us what we need to do in terms of financing this model sustainably, and start to build the sort of network of urgent care services you see in New Zealand, for example. They've got a college of urgent care. Their emergency department presentations aren't just lower than ours, they're substantially lower than ours, because people take those minor emergencies, like when your kid falls off the skateboard or you get a big laceration or something, they take them to these primary care clinics that are able to treat people urgently for minor emergencies, bulk billed, rather than ending up in an emergency department constantly getting shuffled down the queue because real life-threatening emergencies keep coming through the front door. So very committed to this. Frankly, it led to a bit of a mixed debate, I think I'd be honest, in the campaign. But I really think that if we get this right, it can make a major change to people's ability to see a doctor when they need it, but also take pressure off our hospital emergency departments. So that really is the major focus that we brought to healthcare. Obviously, aged care is a critically important piece of reform as well, just left in the too hard basket for too long, particularly in terms of lifting the workforce numbers there, the wages of that workforce, so we can keep them rather than losing them to jobs at Bunnings or in retail or in hospitality, which I've seen happen for far too long in a sector I'm passionate about. We got our first bill through the Parliament this fortnight. It was our first piece of legislation we achieved as a new government, was aged care legislation, and I'm terrifically proud of that. I hope it reflects people's understanding of our priorities, because we have no greater priority than fixing aged care as well. Maybe I'll close, Tony, by saying a couple of things about the consumer place in healthcare policy. I've been around healthcare policy in one form or another for a lot of years, both before I went into Parliament, and then I spent 4 years in the health portfolio under Kevin Rudd and then Julia Gillard. I'm delighted to be back in this new job. And I've always had a very strong philosophical commitment and practical commitment to consumer voice. I know, first of all, it's the right thing to do. It's just the right thing to do. Nothing about us without us is I think, a really good approach to policy making generally, particularly in a policy area that has such a direct impact on people's lives. But it's not only the right thing to do, it's the clever thing to do, because I know through my own experience that engaging consumers or patients, however you want to describe people in this spot, leads to better policy outcomes. I've had that experience myself when I developed a big mental health reform package under Julia Gillard's Prime Ministership, the biggest mental health investment at a Commonwealth level ever at the time. I got an entirely different perspective about priorities from consumers and their carers than I had got from all of the experts and all of the providers who had the ability to fly to Canberra and see me. I remember the Mental Health Council telling me very early on in my time, go out and hold forums with consumers to hear from them what their priorities are for mental health reform. And it was such a rich experience for me and really shaped that package, as it did in many senses, the aged care reform package that I was able to deliver under Julia Gillard's leadership as well. Frankly, the consumer voice in health is patchy. I think we can be frank about that. Without the CHF, we'd be in all sorts of trouble. The CHF, its leadership, its staff like Leanne, bear an enormous load on their shoulders, being tapped into by government, certainly the Commonwealth government, time and time again to provide that voice. And I've already had some really worthwhile discussions with Leanne about how we can use your networks, your capability to improve the consumer voice, the consumer literacy, frankly, about how governments work, how you engage in these sorts of task forces and so on. I'm really keen to continue that discussion. Thanks very much for the invitation to be here today. I hope I haven't gone on too long. And I'm ready to move to your gentle probing discussions now, Tony, if that's okay.
Thanks so much, Minister, and I really appreciate your positive comments about the role of consumers in policy decision making and service delivery as well. Really appreciate it. Over to Leanne now. Thanks, Leanne.
Thanks, Tony, and thanks, Minister. Look, and also thanks for that comprehensive update on COVID and long COVID. I mean, it certainly goes without saying it's preoccupied the whole community for a long time. And thanks also for your sentiment about the consumer voice is the clever thing to do. I don't think you'll get any disagreement from anyone on this call about that. So thanks for that recognition. So we do have, and I think we'll probably have time to get through all of these, and we do want this to be very much a conversation with you. We've curated about 10 questions that we'd like to put to you, and we've got consumers and representatives from across our network to put those questions directly to you across a broad spectrum of issues. As you've alluded to, Minister, CHF is not a single disease-specific organisation. We cover the spectrum of primary care to quality and safety to medicines policy, you name it. So on that note, I'll hand the first question to Deb Robbins. Deb's from Smithfield, north of Cairns. I will not pronounce the country appropriately, so you might do that, Deb, so you can do that justice. But Deb is a member of our rural and remote special interest group. Over to you, Deb.
Thank you, Leanne. Good afternoon, Minister and participants. I'm coming to you from the Gumai, Wallabara, Gidjinji and Jabberkai peoples, and they're the trusted custodians of the land, the seas and the waterways surrounding Cairns. My question for you today, after a lifelong journey with both rare and chronic disease in a regional area, I've maintained an interest in advances from genomics, preventative population health, disease databases and registries, e-health, and down to patient partnerships and research. But listening lately, the experts and agencies behind some of these trial advances seem almost ambivalent to any rapid momentum or systemic change that would make state-of-the-art primary care or specialised care standard practice. They cite a lack of infrastructure, support services, and staffing in regional and remote Australia. When and how will health services become truly decentralised, not only so that regional Australians can access equitable healthcare, but so we all have access to cutting-edge treatment, and this knowledge isn't held up for all Australians? Thank you.
What a terrific question, Deb. And goes to the heart of some of the challenges that I think we've had for many years in this country. First of all, is the tyranny of distance and how we ensure an equitable level of healthcare, from the centre of Sydney out to the geographical periphery of the country. I'll come back to that in a second. The second thing, which is frankly an issue, as much of an issue in central Sydney as it is at north of Cairns or in the Kimberley, is how we get this constant feed of care improvement running from research into actual practice. How we tap into technology and health service delivery. I've said a number of times before, it's a constant source of amazement, I think, to me that a sector like this has some of the least sophisticated technology around service delivery of any major sector of the economy. We are still struggling with a whole range of things in terms of accessing information and communications technology in basic service delivery that banking, a whole range of other sectors just shifted to holus bolus years ago. Everyone now takes for granted. So, the access that your clinicians have to, your scans, your diagnostics, your medical history is still so patchy. It's, I think, a matter of extraordinary frustration to patients. They have to continually tell their story. They have to go back and get tests that they've had before because no one can work out where the results of the last test ended up being. We've got to do better than this. And the Strengthening Medicare Task Force that I talked about had 4 areas it wants to do a deep dive into, one of which potentially the most important, I think, in terms of getting quick wins is technology. But we've just got to do better than that. So this is a particular priority of mine, Deb, and I think it is of the groups, including the CHF, that had that discussion the other day. I mean, it is tricky. It's not like banking in the sense we don't just have 4 organisations that deliver the vast bulk of health services. We have general practice that's very fragmented into small businesses. Essentially, we have 8 hospital systems and all the rest. It's not easy, but it's got to be something we do better. In terms of the sort of services in rural and remote Australia, one of the things I'm becoming increasingly convinced about is the value we get from regional planning and regional commissioning of services. We've seen some really interesting pilots. I was only talking to Ian Hickey this morning about some work he's been doing in northern New South Wales, working between Commonwealth-funded services and state-funded services, actually cooperating together to map, plan, and then commission services across a region, rather than having people confused about whether they should be talking to the state or whether they should be talking to Commonwealth services. And that's actually working better in regional Australia, where we're piloting it, than it is in the cities, because a whole lot of the services there know that to be viable, to be able to deliver basic care, they've got to cooperate in ways that is often hard to get organisations to do in the big cities. I was only talking to health ministers this morning about the need for us to do more of this, to trial more regions where this can happen, show that it can work, and then start mainstreaming it.
I need to get my video back on. Thanks very much for that question and that answer, Minister. The next question, probably we're going to take the imprimatur that we have as a consumer organisation to ask 2 questions about consumer issues. So the first one, Minister, comes from Renza Sibilia, and she represents Diabetes Australia, one of our valued members, and she's in Melbourne.
Thanks, Leanne, and good afternoon, Minister. Yes, I am coming from beautiful Wurundjeri land. My question is, I'm interested to know what measures are in place to ensure that you are meaningfully engaging with health advocates in the development of broad and also specific policy.
Thanks, Renza. It's a lot of books you've got behind you.
Yes.
Thanks. Look, I'm only 8 or 9 weeks into this job, so we're still building what I think will be a different approach to the last government. I mean, that's what you get when you elect a new government. And as I've said, and as I've said to Leanne on a few occasions, we've been able to talk as well. I really am committed to trying to lift the consumer voice in policy making and service delivery, but particularly policy making. So, I'm certainly trying to make sure that as we're doing big pieces of work, and the strengthening Medicare is the one I've spoken about a bit already today, that there is a strong consumer voice in that work. I've said, for example, I've said publicly, the primary care plan talks about voluntary patient enrolment as being a very big part of primary care reform, strengthening the relationship between a patient and their doctor and the practice more broadly, so nurses and allied health workers working there. But I'm not confident. I've been open about this. I'm not confident, although clinicians are very attached to this model, and I understand the policy rationale for it. I'm not confident that the value proposition for patients has been clearly articulated. Like what are patients going to get? What are consumers going to get out of this system? Get what be good for practices. What is the patient going to get out of that? And I've issued that challenge to the doctors groups that are litigating the case for voluntary patient enrolment. So it's not just about having people at the table. It's about making sure that when we're thinking through potential policy changes or policy initiatives, we're constantly asking the question, what does this mean for consumers? Not what it means for providers. I mean, this is I think, a challenge beyond health, constantly as government, that frankly, in every policy area, health, resources, doesn't matter what, finance, governments are always closely engaged with providers in that policy debate. We've constantly got to discipline ourselves as governments to keep the interests of consumers at the front of our mind, and that's what I'm trying to do. So, as I said, though, in terms of the system-wide capability, because this is a sector that has so many stakeholders and so many fantastic provider groups, clinicians and service providers and so on. There's no shortage of perspectives as a government minister of those views. We constantly have to nurture the consumer voice, I think. Not nurture it in the sense that there are sort of 25 million consumers across the country who have a view about how healthcare should be delivered, but nurtured in the sense that it's able to be marshalled, it's able to be trained, mentored, and supported to participate in policy-making debates. And as I said, I think in my introduction, I'm interested in talking to the CHF about that, in a more focused area. When I was the mental health minister, one of the things that I funded in a budget was the establishment of a new consumer organisation in mental health. There had been one years earlier. It collapsed. Organisation. I came back to the portfolio 9 years later, and it still hadn't been put in place. So you've got to sometimes work hard at this. There are areas of health where there's a really strong consumer voice and a strong consumer presence at the example of that. There are areas of health where there's a very shallow voice. And as a minister, I'm really keen to understand, I'm only 9 weeks into the job, but keen to understand across the health spectrum where those gaps are and how we can lift that capability.
Thank you.
Okay, thanks for that answer, Minister. We've got another consumer-related question, consumer engagement and participation question. This one's from Nicole Millis. She may well be known to you, Minister. Rare Voices Australia's CEO, again from Melbourne.
Hi, Minister. Thank you for today. I'm also on the land of the Wurundjeri people of the Kulin Nation today. My question is around consumer-led health and disease organisations. They're an important part of the health sector, particularly in the rare disease sector. Yet those organisations are often under-resourced, largely volunteer-based, often reliant on volunteers who themselves are living with a rare disease, or their long-term organisational sustainability is uncertain. How will the government ensure that this person-centred part of the sector builds capacity and is strong and sustainable?
Thanks, Nicole. Thanks. Great to see you again. Look forward to working with you in a new capacity. Well, I'm in a new capacity, you're still in the same, but really look forward to working with you. As I said, one of the things I'm doing as a new minister is trying to get a sense of what support arrangements were in place from the former government. So as you know, many others on the webinar might know, that there's a range of different arrangements that are in place. There's sometimes core funding, particularly to some of the peak organisations, and then grant funding that can be provided for particular projects. I know that places a lot of pressure on organisations that are already not well resourced to have to sort of continue to apply for grant after grant after grant. That can take you away from doing your core work if you're constantly involved in putting in these applications. I don't yet have a good and complete sense of where the department is up to with its arrangements. Frankly, I think some of those funding support arrangements were cut after we lost government last time. So, I know a number of organisations I've been dealing with had their funding removed. We've already been able to reinstate that, particularly in areas that we're very concerned about, health areas we're very concerned about right now. But I just encourage organisations to, we're at the point as a new government where we need feedback, about where the gaps are. I mean, I can talk to my department, I can read briefs. That's no substitute though for getting direct feedback from people on the ground who are doing this really important work. So that's about all I can really say to you about that, Nicole. 9 weeks in, still pretty early days, but I'm finding gaps and trying to fill them where I think it's really important.
No, that's fine, and we look forward to further discussion. Thanks.
Thanks, Nicole. Thanks, Minister. Shifting now to Sophie Athen. Sophie's a consumer advocate from Melbourne. All these questions from Melbourne. We'll get to other parts of the country soon. Sophie?
Thanks, Leanne. Thanks, Minister. Thanks for the opportunity. I come from Wurundjeri land of the Kulin Nation. Beautiful, beautiful landscape, as you can see behind me. My question is, you must have noticed the disparities in health outcomes across Australia, and reducing inequities will require carefully targeted and strategic action. And one potential way is to look at how health is funded. Following the recent election, where there is now a Labor government leading federal politics, what what are the opportunities to streamline funding models with the states and territories to address health equity matters around access to healthcare?
So that's a beautiful backdrop you've got there, Sophie, and a terrific question. And frankly, I think the question that we have always grappled with in the Medicare era, Medicare is a great legacy and one we're very proud of as a Labor Party, but the universal right to healthcare is very different to the universal and equitable access to healthcare. And particularly given the private delivery model that was largely, it's not the NHS, the private delivery model of non-hospital care that is in place here in Australia, it's essentially a matter for doctors and other health practitioners to decide where they set up. And that means that often the further away you get from a GP to regional Australia, the less access you have to healthcare services. We know that, and I think it's been a constant challenge to try and address that market failure. When I was just give you an example, when I was the new mental health minister in 2011, we got the first evaluation of the Better Access scheme, which is a scheme that gave Medicare support to psychology, essentially. And it had been enormously successful in the sense that it got much more buy-in than the Howard government had initially predicted. Howard government put it in place. But what we found through the evaluation was that 3 times as many Medicare services, 3 times as much Medicare funding through Better Access was spent on the richest 20% of the population as was spent on the poorest 20% of the population. It's not because the poorest 20% of the population is 3 times as healthy in a psychological sense as the richest. It's because the clinical psychologists were much more likely to set up in those wealthier areas of the country than in the poorer areas. So what we did as a response to that was substantially lift funding to what we used to call Medicare locals, now the PHNs, to fill that market failure and to deliver bulk build psychology services in the outer suburbs of our cities and in regional Australia, where frankly the private services just weren't setting up. That for me was a very sort of important experience. We had other great mental health programs like the Mental Health Nurse Incentive Program, essentially privately delivered. Not a single service was delivered in the Northern Territory, and only 2 or 3% of the services were delivered in Western Australia and South Australia. Not because those services weren't needed there, but because the delivery model essentially didn't take account of need. It didn't take account of equity. So as a minister, as a government, it's our job, given the nature of our healthcare system, which is a private sector delivery model, it's our job to constantly monitor the equity of that service delivery, and where we find market failures, to use the hand of government to fix it. And that's not easy. We know, and I'm sure, Sophie, it's use of incentives, use of other programs to move medical services into those areas that are underserviced is hard. Like it's hard work. We never quite nail it. But it's given that we don't have an NHS, a government service delivery model, we have a private service delivery model, then it's got to be something we continue to do.
Thanks, Minister. And I really look forward to some future discussions around some of the themes that impact on consumers and access to services. Thanks again.
Thanks, Sophie.
Thanks, Minister. And I know there's been a lot of discussion just today, actually, on Twitter. You mentioned that you'd met with Ian Hickey this morning about mental health, and there's been questions asked about the extent to which mental health and better access and reforms to that are in the scope for the for the Strengthening Medicare Committee or not. So I've got a question on mental health for you now from Maximilian de Courton, Professor Maximilian de Courton. He's the director of the Mitchell Institute, one of the academic units that we work very closely with at CHF. We seem to have you on mute, Maximilian.
Back on mute.
Well,
There you are.
well,
There you
it's
are.
good if you can hear my question, I guess. I was just saying I'm also based like Sophia on the country of the Wurundjeri people, but my background is not as green. But anyway, I'll give you a context to my question. It's also about equity, because as you might know, there is an up to 23-year lifespan gap for people living with serious mental illness and those not having been diagnosed with them. And despite various national commitments, little has changed in the poor physical health care of this group. More than 400,000 people in Australia live with serious mental illness impacted in their physical health by this. So recently our institute led a project where consumers and carers working together with frontline clinicians and chronic disease experts developed measures of success for policymakers and practitioners to achieve a focus on collaborative care. These measures call for improved physical health care through trusting relationships between individuals and GPs with swift access to health checks and treatment. These recommendations are available to your office. And now here's my question. How will you and your office address the physical healthcare neglect in people with serious mental illness, including through the Strengthening Medicare Task Force you mentioned already?
Thank you for that question. This is an area of policy we were starting to address at the end of our government. We put in place a range of new mental health support measures for people, the group you're talking about, people with severe and chronic mental illness, many of which have been rolled into NDIS, so they're not as apparent now, but programs we design, like Partners in Recovery and expansion of FAMs and other psychosocial supports, we're starting to make a real difference. But I remember being part of a sort of big symposium in the New South Wales Parliament, where it was laid out to us just how poorly we were doing in the area of physical health for this cohort. You've talked about the statistics, but I remember very clearly, even though it's more than a decade ago, the presentation about the percentage of this group who were having basic lipids tests, blood pressure tests, and if they had the tests, the lack of follow-up. The clinicians would say, because frankly, all of the minutes that they had in their consultations were taken up looking after people's mental health. So, we were starting to look at ways in which we could better manage that aspect of people's health. We lost government. I've lost track a bit of where that went. The Strengthening Medicare Task Force, as I said, I think to Renz's question, is looking at how you strengthen the relationship between a doctor or a practice on the one hand, and particularly people with complex chronic needs. This is certainly a cohort that meets that definition. They're fairly early days in working out how you do strengthen that relationship, and what obligations the doctor carries, frankly, or the practice carries with that in terms of checks and tests and so on and so forth. But I'm really keen to having been away from this debate a little while, and being new back into government, as I said, very keen to understand that. And I'd love for you to be able to send that material to me, if you could, because it's an area that I was really quite struck by in the really the back end. It was only really presented to me in the back end of my 3 years as the mental health minister.
Thank you.
I might also just, Leanne, respond to your the point you raised that apparently was being ventilated on Twitter. As you know, I think, Leanne, there's an evaluation of better access underway right now, which we inherited from the last government. It's not complete yet. So we're waiting for that to be completed and delivered to us, but that's probably still a couple of months away.
Mm-hmm. Thanks for that, Minister. Telehealth now. We know we've done a lot of research, as I said to you, at the Strengthening Medicare Committee about telehealth, and there's no doubt that the community and consumers have really embraced telehealth and all things digital. We've had such acceleration in that area. So a question on that from Nadia Moffat. She's actually in your electorate, from Henley Beach in Adelaide. Over to you, Nadia.
Hi, Minister. Thank you for your time today. I too come from the Ghana lands and am very happy to be here. During the pandemic, telehealth became an option. A further investment in telehealth could help provide accessible healthcare and provide a solution to the shortage of GPs. Does the Commonwealth Government have a plan to expand telehealth, and what does that look like?
Thanks, Nadia. Very lucky to live in a beautiful part of the world, Henley Beach. Telehealth. The pandemic has largely, overwhelmingly been an awful bloody thing for everyone across the world, but it has compressed our progress in some areas from what might have been years and years into a very short time. It's reminded us how clever our health research scientists can be in developing vaccines that you remember in early 2020 people said might never come along. Now we've got lots of them. And it's also hugely accelerated our uptake of telehealth, which had been really sort of muddling along for years and years. I mean, when I was mental health minister, we funded the rural psychiatric telehealth program, which was immensely successful and stopped people having to travel. I remember when we launched it in Perth. People were being removed from Kununurra, which is as far from Perth as Sydney is, to have a psychiatric assessment. And it just transformed, often taken off country. So it transformed our ability then, but we just didn't really shift much over the last 10 years. I mean, that took off like a rocket through the pandemic. Telehealth, as you know, was something that was being renewed almost on a 6-monthly basis. It's now a permanent feature of the Medicare system. To be frank with you, probably the area of controversy is that the former government had taken a decision that from the 1st of July, consultations over 20 minutes must be a video consult, sort of like we're doing now, rather than just a phone. The advice that Greg Hunt received, is the same advice that I've received, which is that for longer, more complex consultations of over 20 minutes, it's best to have a visual element to that consultation rather than just over the phone. Now, 6 out of 7 telehealth consults are less than 20 minutes, so they're not affected. They can continue to be phone or video, whichever people prefer. But that 1 out of the 7 consults over 20 minutes, Greg was advised, and then I was advised, should have a video content. So that decision that Greg made, we continued with from the 1st of July. That was the change. Now, I made an exception to that for antivirals, so you can still get a phone consult for antivirals, even if that extends beyond 20 minutes. But we've still got this controversy around the 20-minute plus consultation, whether that should have a video element. I think there are different perspectives around that. Some of our advice is, for clinical quality, there needs to be a video element. Some of the doctors' groups say to me, it should be our choice. And if we want to have a longer consult over the phone with a patient, then we should be entitled to do that. Some of the consumer groups say that they prefer that choice as well. I think, to be honest really blunt about this, Nadia, is, we should recognise this is new. And, when I've asked people for, including my own department, for some research, some evidence about these quality questions, there isn't much, because no one's been doing this for very long across the world in a really at large scale. It's only really been large scale through the pandemic. So, you know, I've said to doctors groups, I think I've said to Leanne, like, you know, we are going to continue to learn about this, and we should, and I as a minister should keep an open mind and be open to evidence that takes us down one path or another, because what is utterly clear to me is that this has been a real game changer for some patient groups, some people who, you know, find it hard to get out and about, some people who might not be near their doctor or other health professional. This can be a real changer and a real game changer, and it can be a real efficiency as well. You know, if you're talking about just getting an update from your doctor on a test, and all you really need to do is that, well, you know, why do people have to bother traveling around and you know, going into a consult room and doing all that? The last thing I'd just say about it, though, is that, you know, again, to be pretty frank about this, there's a pretty variable level of capacity in general practice with IT. We went to the election with a round of infrastructure grants for general practice, $220 million of grants for general practice to strengthen their practice, really, to upgrade their systems. And I've tried to make it really clear to them that one of the things we want to be a focus of that money is IT upgrades, you know, because I am one of the things that the doctors do tell me is, I don't have the capability to do video calls well, and well, frankly, they should. That's not a criticism of them, but they should be supported by government to be able to upgrade their systems so that they're able to offer the full suite of services to their patients.
Thank you for that, and thank you for my birthday card this week.
Pleasure. Happy birthday.
Thank you.
Happy birthday, Nadia.
Thank you.
You mentioned the GP workforce pipeline earlier in the webinar, Minister, and I think, you know, there's without a workforce, we don't have a system, and comprehensive healthcare in the community is delivered by a multitude of clinicians from different craft groups. So over to Dan Kent. He's a consumer advocate from Tweed Heads to ask a question about the nurse workforce.
Well, thank you, Leanne. I'm coming from Bundajaranga countries here in beautiful Tweed Heads, Minister. My question is relative to the nursing workforce. Minister, Health Workforce Australia, August 2014 report advised that Australia's demand for nurses will significantly exceed supply, with a projected shortfall of approximately 85,000 by 2025 or 123,000 by 2030 under the then current settings. The report also showed that no single policy scenario could successfully fill the gap between nursing workforce supply and demand. However, a combined scenario demonstrates that the initial shortfall can be significantly reduced to approximately 39,000 by 2025 or 45,000 by 2030. Minister, are you aware of current shortage projections, and what initiatives will you take to address this alarming shortfall predicted well prior to the COVID impacts?
Well, thank you, Dan. It's a beautiful part of the world you live in, really is. That must have been one of Health Workforce Australia's last reports before Tony Abbott abolished them, which was a great pity. I was Nicola Roxon's junior minister when we created Health Workforce Australia, and it wasn't perfect. I think if we did it again, we'd maybe do it in closer cooperation with state governments, that obviously state health systems that play such a big role in these workforce areas. But it did some really good work. And what it was a group of people whose job every day of the week was to think about the workforce needs of Australia's health sector in the medium and long term. And when HWA was abolished, it wasn't replaced with anything. And we've had a sort of a potpourri of different workforce strategies without much cohesion around them. And so, Leanne's right. Although I'm terrified by the pipeline of general practitioners, there are shortages now, and shortages likely to get worse in most areas of the health workforce. The health ministers and I spent a couple of hours together this morning, and the vast bulk of our meeting was spent talking about workforce needs. Now, nurses is probably a bit of a gap that we have. As I've come into government, there are some different strategies in place. There's a medical workforce strategy the former government put together. There's not a nursing strategy. And so I've talked to my department already about the need for that, given how utterly central the nursing workforce is to the operation of every element of our healthcare and aged care system. My initial sense, and this is without prejudice because we've just not done the work on this, my initial sense is that we're getting pretty good numbers out of our universities, and our bigger problem is keeping them in the health sector. And if they go away for a while to do other things, getting them back in, that's certainly in aged care something that's utterly clear through the survey work. There's a whole bunch of our 400,000 nurses who really want to work in aged care, but just the staffing levels, the poor wages mean that they just simply can't. And survey after survey show that if we sort of had proper staffing levels in place, if the wage gap was a bit narrower between aged care and the hospitals, we'd be able to get more back. More than 80% of RNs working in aged care are working part-time. Now, I'm sure some people want to do that, but we know from survey work again that a lot of those nurses want more hours. And so just being able to hold them in the workforce is the real challenge. You're right, though, the just given the demand for healthcare that is created by an aging population, let alone the increased incidence of complex chronic disease, we are going to need more. And I think what is clear, some of the international bodies, you're probably across this, Dan, are doing some assessment of the global shortage of nurses, which runs to millions. And so, I think we used to take for granted as the lucky country, why would people want to come and work here from wherever around the world? Great beaches up in northern New South Wales and so on and so forth. We're finding that we're struggling. We're struggling to compete with a whole range of other countries that are keen for overseas trained nurses to come to their country and supplement the local workforce. So I think it just comes back to my first point, which is workforce is so central. You can't put machines in and deliver healthcare. Workforce is so central. The lack of a really strong, coherent national workforce strategy, I think, has made a bad situation worse. And nursing in particular is something, as when I came in my very first few weeks, identified as a gap.
Thanks, Minister.
We don't have a nursing strategy as a country.
Thanks, Minister. Can I just check in? We scheduled the webinar to 2:15. Have you got time for another couple of questions, Minister? We're sitting at 2 o'clock now. Yep, beautiful.
Yep.
Okay, you touched on long COVID in your introduction. This is a question about that from Christine Gonson. She's a consumer representative involved in research from Perth in WA.
Good morning, Minister. It's morning here from Wadjuk, Noongar country. Yeah, only just. There's a considerable strain across the communities that I know on primary care GP frontline dealing with long tail COVID issues. As GPs can be hard to get into, they often don't get feedback about, for example, what has worked for people. Patients don't return once they feel some improvement or give up and go and live with their persistent symptoms such as fatigue, headaches, and respiratory complications. What action can be taken by the government to invest in systems for sharing effective frontline practice, like building an evidence base, to assist in this response of the primary care sector to this new emerging challenge?
It's a terrific question, Christine. This is such a diabolical phenomenon, both in its scale. We don't really understand the scale in an accurate sense, but we know it's going to run to hundreds of thousands of people. But just its variability. I mean, this virus seems to get into almost every part of your body. Yeah. I think I said in the Parliament that the medical literature has tracked 200 different symptoms of long COVID. I saw a piece over the last 24 hours suggesting it's over 60, whichever, you know, although there are more common symptoms than others, the real challenge for patients and for their clinicians or their doctors is identifying it, because there's not just one or two clear symptoms. So that's the first thing. Already I'm talking to people in my personal life and my professional life who are really having trouble having that conversation with their doctor, because it's sort of it's so variable, everyone's experience of this phenomenon. And then the third thing is, we don't know how to treat it. We don't, you know, I've talked to very senior experts who still don't really understand what's driving this. Is it that COVID causes a sort of particular response from our immune system that then impacts a whole range of our other organs, you know? So not even really understanding what's causing this, I think, is hampering our ability certainly to treat it. What is crystal clear, though, is that, and I think I might have said this in my introduction, I certainly said it in the Parliament this week, is that I think having come into the government, this is not a particular criticism of the former government. I just think people have been so focused on managing the day-to-day challenge of the pandemic that we haven't yet focused enough attention on building a strategy around long COVID. And to your very clever question sort of points out, it's going to have a number of layers. Importantly, evidence and research and awareness. So you know, I'll just be frank, that work hasn't been done. I'm not sure it's been done anywhere. There are lots of clever people starting to do that work, but rolling it out system-wide, I don't think it's been done anywhere around the world. I'm very committed, and I've talked to the CMO on several occasions. I've had a discussion with health ministers this morning. As we sort of get through this third wave over coming weeks, we're in the process now of developing our plan for the next phases of the pandemic. You know, public health measures, vaccines, all those sorts of things. And I've made very clear my expectation that a long COVID response, or long COVID strategy, now has to be a key part of that. We're at that point, I think, now in the pandemic. We may have been there earlier, but we're certainly there. We're certainly there now. But I'll be honest with you, I'm not really sure yet what it looks like. I've seen nothing where people have done the hard work to map that out clearly for policymakers.
Thank you.
You could say a work in progress.
I hate to say that. I mean, I'm sorry I have to say that. I just want to be frank with people, Leanne. And it's not like I think we're running behind other countries in the world that have worked out how to do this.
Well, we'll just do the last question, Minister, on aged care, which is another big important area of your portfolio. And I think for those of us in a particular generation, we are a sandwich generation. We're sort of looking after kids who are staying at home because they can't afford housing and all sorts of pressures on that end. But then we sort of sit by in frustration as we watch our parents try and navigate the system. So this question I'm going to put to you. It's on behalf of Barbara Newman, another one of our consumer advocates who was unwell and couldn't be with us today, but it is one that I wanted to end on and draw out your thoughts on. So she says she's disturbed about the lack of community support for older, newly discharged pensioners from the acute care environment. In many cases, these people are not being case managed. They're falling through the cracks with no care organised, no meals organised, no bathing arrangements organised. Aged care has got to do better. Older people need to be managed in a seamless way, not discharged home with no backup support. What is the Minister doing, or what can you do about this? How can healthcare provide seamless transition together with adequate resources to support these folk?
One of the sort of structural challenges our health system has, and people on the webinar know this, is its fragmentation. We don't have a single payer. States are responsible for some things, Commonwealth are responsible for others, and through no lack of goodwill, just the way the world operates, there's often, if you're exiting my system into another person's system, well, you're off my hands. You're not my responsibility anymore. And both levels of government do it, and always have, unfortunately. So, too often we have seen a patient move from one area of the health system to another with very poor handover. Whether it's discharge planning out of hospital, or whether it's shifting from the NDIS into hospital, there is this sort of tendency to wipe your hands as a level of government. And I want to really stress both levels of government have done this. We're only again having a discussion this morning with health ministers about how to do better, have better protocols, and do better discharge planning of people living with a disability out of hospital into the community, or aged care residents out of hospital into the community. Because it's in the interest of states to do this, because if there's not proper discharge planning, there's a tendency for people just to stay in the hospital, in some cases for months and months and months. So, this goes back, I think, to Deb's question. The key is better linkages. The key is not allowing the system to remain fragmented, particularly for vulnerable older Australian who's not going into an aged care facility, going back into the community, into their own home, is being discharged from hospital. There should be a good discharge plan, and that discharge plan should be linked up with their GP, or if they have a home care provider or their home services provider. It's just common sense. And yes, people in hospitals have run off their feet. Completely get that. It's about resourcing. We said today at our discussion, Bill Shorten and I said today at our discussion with state health ministers, yes, the NDIS has to resource people into the hospital so that there are people there to think about what's going to happen to this person once they leave the hospital itself. It's about resources. It's also about systems, so that, I talked a bit about how relatively poorly, I think, a wonderful healthcare system at a global level, how poorly we do ICT. We've got all of these different electronic health systems. My health record, a whole lot of stuff's not uploaded to my health record. So getting that is really the key. I think those better linkages. We're not going to, we tried a bit under Kevin Rudd when I was in the health portfolio. We tried to sort of move to not quite a single funder system, single payer system, but much more integrated. Didn't really work. But there are some practical measures we can take just to improve those linkages, so that as someone is moving from one system to another, they don't fall between a gap. Barbara's question, I think, just speaks to a lot of experiences around the show.
Yeah. And you're right to say that it's just common sense, and you know, if only we could get the systems and the practices to follow through on that. There's so much. Well, there's better patient experience and better patient outcome, but you know, the quintuple aim, as we talk about now, and workforce
Absolutely.
satisfaction and health workforce having joy in work, having those systems and smarter discharges and timely discharges, to pick up on your example, just makes such a difference to how efficiently the system works as well. So
well, we know the evidence. We know the evidence that where we do it well, the number of readmissions plummets.
Yeah, exactly.
So I mean, that's obviously most importantly. That's much better for the patient's quality of life, but it's also cheaper for us.
Yeah, and it's often, you know, it's I mean, you can always put more money into a system. You can always put more money into health, more money into aged care, but it's also about doing different, not necessarily doing more. So thanks for your answer on that, Minister. I'm just conscious we are up for time. So on behalf of the CHF board and all our members and network partners and collaborators, we've got many online from that broad church and our consumer representatives. Can I thank you again? You've been incredibly generous again with your time for us, over an hour on a webinar. I know you're in high demand, media and all of those sorts of things, and health ministers meetings, so we really do appreciate the time you've given us. What we're keen to do, and we'll come back to you, I'm sure, as CHF, to pick up the threads on those conversations with you about what can be done to lift the voice, lift the consumer voice, and lift the capacity for that to happen more systemically and strategically. We've had those conversations, and we'd like to do that in a forum later in the year with you on that specific topic, with our members involved in that conversation. Tony, did you want to say some closing remarks? I still see you online there. Yeah.
Unfortunately, I can't turn my video back on because Kate won't allow me back in. But anyway, be that as it may. Thank you so much for your time, Minister. This has been a great conversation, and as Leanne said, not the beginning, because we've already had conversations with you, but to continue having fruitful and constructive conversations with you throughout your term, and anything we can do to help, we're up for it, and we look forward to ongoing constructive, positive relationships with you and your governments. Thanks so much.
Well, thanks, Tony. Thanks, Leanne, and thanks to everyone for a really great discussion. Look forward to doing it again.
Okay.
Thank you so much.
We'll sign off. Have a good week, everybody.
Bye-bye now.
Bye.
Good weekend.
Bye. Bye.